Hello, I'm Dr. Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance and associate professor at the University of Washington and Fred Hutchinson Cancer Research Center. I'm very excited today to discuss with a wonderful colleague and scientist and investigator, Dr. Simon Crabb. Simon, do you want to introduce yourself?
Thank you. Yeah, so my name's Simon Crabb. I'm a medical oncologist, and I work at the University of Southampton in the UK.
Thank you, Simon. It's great to discuss with you. We both were together after 2 years, right, at ASCO GU 2022. We saw some exciting data. Great to see you in person in a safe way. I was really excited to see a lot of data in the field of bladder cancer, urothelial cancer. I will very briefly mention the non-muscle invasive disease. I saw this data by Dr. Karim Tseimi with BCG plus N803 in the BCG responsive disease. Very quickly, you had any thoughts? The clinical complete response rate looked pretty interesting there, right? In the context of pembrolizumab data, nadofaragene data. Any quick comment on that?
I think so. I mean, this is a really interesting area that I think a lot of us are starting in the oncology sphere are starting to have to think about an awful lot more in terms of, what are the appropriate endpoints for these trials? What is clinically meaningful for our patients? It's probably not survival in these trials because these patients generally don't have their life at risk. So you're having to think about other endpoints, bladder preservation, avoidance of cystectomy. So yeah, I thought it was interesting data. There's clearly quite a high response rate. And really interesting in the context of obviously a number of emerging data around immunotherapy, and we've got phase 3 data coming in the not too distant future. So I think it's a really interesting area and potentially a lot of work, of course, if we can get these treatment approaches to actually work.
Totally agree, Simon. And I think you made important points there. Again, for the audience, this was a study combining intravesical BCG and interleukin-15 superagonist, the N803, presented by Dr. Tseimi in BCG responsive carcinoma in situ, looking at very high clinical complete response rate. This was a single-arm study, not randomized, but really the data indirectly, looked favorable compared to the data we had from other agents in that setting. But the challenge that, Simon, you alluded to is the lack of randomized trials there, but definitely exciting data to see in the BCG responsive high-risk non-muscle invasive disease, especially for patients with inability to get radical cystectomy, cannot get radical cystectomy or refuse it despite counseling. I'll move on, Simon, to the neoadjuvant setting, and both you and me believe that neoadjuvant cisplatin-based chemotherapy is standard of care before radical cystectomy for those who undergo surgery. But many patients are not fit for cisplatin, and we saw some interesting data from Dr. Petrilak, cohort H of the V103 neoadjuvant and enfortumab vedotin single agents in patients who are not fit for cisplatin. 22 patients, pathologic complete response rate, 36% pathologic downstaging, 50% toxicity profile as we expect from data in metastatic disease. But there were 3 patients out of 22 who died after surgery, and there was some question there about that, and they're ongoing phase 3 trials. So how do you see this data, this early stage data?
So I thought it was really compelling. Obviously, this was enfortumab, an antibody drug conjugate directed at Nectin-4. Obviously, this is a treatment that is now established in advanced disease. We've seen positive phase 3 data. So this is part of our armamentarium going forward. So really interesting to start to see evidence for whether or not this is going to be beneficial in the neoadjuvant setting. I think a pathological complete response rate of 36% is competitive compared to the alternatives. And of course, you're not comparing with the group of patients you can give cisgen to. So actually, that's quite an impressive clinical response in a group of patients which you can't give chemotherapy to. It's a small trial, a very small trial. It's single arm. There's no randomization, and I think this is the starting point for how we might develop options for this group of patients. I have to say, it's interesting. At one stage, I did wonder how easy it would be to recruit patients who you can't give chemotherapy to, you can't give cisgem to, into trials in this clinical setting. But actually, certainly our experience in the Abacus trial, which was looking at atezolizumab, these are patients that you can treat. I think there is a scope to think about how you can approach trying to improve on outcomes from cystectomy alone. And enfortumab clearly is a potential option, and we ought to look forward to seeing randomized data. As you say, there was a question about 3 perioperative deaths. I think we need to see more information about what happened in that situation. The suggestion was that these were felt to be perioperative, in other words, relating to the surgery rather than the treatment. But even so, clearly we'll need to see more information, and that will need a lot of scrutiny in future trials.
Thanks, Simon. Thank you. I agree. It's very, I would say, encouraging efficacy data. I think definitely support the ongoing phase 3 trials with the Keynote 905 and Keynote B15, right, with pembro-EV in a randomized fashion. But as you said, what we saw at ASCO GU was not practice changing yet.
Absolutely, and I think that was kind of the message, to be honest, for ASCO GU overall. That there wasn't a practice changing big study that's going to change what you do with your patients next week, but there was a lot of really interesting phase 2 data, such as the enfortumab study, that I think pushes us forward and sets up where we should be going next for phase 3 studies and design of current phase 3 studies. So it was that sort of data mostly, I think, at the meeting.
Absolutely, and talking about promising data, we saw some interesting data, Simon. In the upper tract disease setting, there was some neoadjuvant data by Dr. Yip, I think, with gemcitabine cisplatin, 57 patients neoadjuvantly before radical nephroureterectomy. And it was interesting that, it was a very, I would say, compelling pathologic downstaging. And I think, if I remember correctly, the pathologic complete response was about 19%. So 19, right, and lower to what we have seen in bladder cancer, but maybe upper tract is a little bit different disease. Any comments on that?
Well, so I think that's my first kind of thought about this is what is competitive, what's an acceptable pathological complete response rate in this clinical setting? I'm not sure that we know that. I think the clinical response rate was high, was about 63%. So clearly there's responsiveness. I don't think that's a huge surprise. I think you would expect a relatively high response to platinum-based chemotherapy in these patients. But yeah, I mean, the first thing to say, this is a difficult setting to do trials in at all. So the fact that they got this done, I think is something that they should be very proud of, actually. It obviously feeds into a debate about how do you sequence treatment options in this clinical setting. I'm from the UK. We have a proud history of doing the BAYOU trial, which is obviously an adjuvant study, and so that's our current standard of care. But there is obviously this open question of what's best in terms of the pathway. Is it better to get in with the chemotherapy beforehand? Does that help with your long-term outcomes compared to adjuvant treatment, where you might struggle to treat as many patients potentially? And of course, coming over the horizon is the question about how you fit immunotherapy in. So there's some logic about chemotherapy before surgery and then immunotherapy potentially, depending on how you view the current status of the adjuvant immunotherapy data, balanced against the fact that we have a positive phase 3 trial from POUT with adjuvant chemotherapy. So I think there's a lot to discuss there and think about with how we approach this with patients.
Absolutely, and the question is still open, as you said, neoadjuvant or adjuvant, and we just launched the phase 3 trial here in the US with the ECOG-ACRIN, the ECOG-ACRIN 8192 trial. This will be a phase 3 with dose-dense MVAC, with or without durvalumab in patients who are fit for cisplatin, and those who are not fit for cisplatin, they will go for gemcitabine durvalumab single-arm phase 2 for cisplatin unfit patients in the neoadjuvant setting. But to your point, how do you reconcile the data, from Dr. Bittle and or the great group you have in UK with the POUT trial? So a lot of activity in upper tract. I'm very excited to see data in upper tract disease.
I think this is a rare cancer in effect, and so the fact that we're now able to see multiple studies coming through for this group of patients in itself is actually quite a novel thing. So I think that's something that we should be very impressed by.
Totally agree. And moving to metastatic disease setting, I think most of us would probably treat a patient in the frontline setting of advanced urothelial cancer, metastatic disease, or unresectable advanced disease with platinum-based chemotherapy followed by switch maintenance avelumab for those with response to stable disease. And we saw some very interesting data. We had a longer follow-up at the JAVELIN Bladder 100 trial with Dr. Pauls, myself, and others. And we saw that with longer follow-up and a significant proportion of patients getting second-line therapy, I think it was about 3/4 of the patients in the best supportive care arm of the JAVELIN trial getting second-line therapy, the hazard ratio remained significant, went a little bit up from 0.69 to 0.76, but still remains significant, which I think just speaks to the strength of the overall survival benefit in the switch maintenance avelumab trial. And on that context, there was some very, very interesting data, I think, looking at switch maintenance, not immunotherapy, but PARP inhibitors. And Simon, you presented some very compelling data with ATLANTIS trial. You want to comment on what you just talked about in the context of JAVELIN?
Sure. So yeah, we presented data that comes from a platform study called ATLANTIS, which we have run in the UK. So this was a study where we took patients coming through first-line chemotherapy with platinum, and we undertook biomarker pre-screening. And on the basis of their pre-screening data, they were allocated based on biomarker status to a number of maintenance studies run in parallel, each of which was a placebo-controlled phase 2 study. So the data we presented at GU ASCO related to the rucaparib arm of this trial, which was for patients that had a biomarker that was relevant to DNA repair deficiency. So basically, either patients had to have high genome-wide loss of heterozygosity, or they had to have an alteration in their cancer in a particular DNA repair gene. We had a list of 15. So the study, I mean, first of all, was undertaken before the data for avelumab. So that was the reason that we felt it was appropriate to have a placebo control arm. The trial was positive for its primary endpoint, which was progression-free survival. And we saw median progression-free survival of 35 weeks in patients that got rucaparib compared to 15 in patients that got placebo. So the hazard ratio was 0.53. And our conclusion to this is basically that we think that this justifies further development of PARP inhibition. And we think it probably does have to be within biomarker selected groups. And we might get on to some of the other data at this meeting that had looked at unselected groups of patients with PARP inhibition. Our view is that there is justification now for launching further studies, but it's going to have to be in a biomarker selected subgroup of patients.
I agree with you, Simon. I think patient selection is key. And I think the holy grail is to find the right biomarker for PARP inhibition. I think you're right there. And we have had trouble so far, in the ATLAS trial or the BSK trial that we published in the past. And we saw data from the MITURO trial, right, with switch maintenance niraparib, right? And this was a negative trial, no signal there.
It was. So their study, this was an Italian academic study, as you say, with niraparib. But they looked in an unselected group of patients. The trial was negative. They had the biomarker positive subset was too small in that trial to analyze, really. So I think it's consistent with the idea that in all comers, PARP inhibition is probably not going to work. With a degree of selection where we have an efficacy signal, I certainly don't believe this is practice changing at the moment, but I think we should do more work. The other thing to say, of course, we did two forms of selection in our trial. We did it partly on the biomarker, but of course also this was maintenance treatment. So these were people that had clinical benefit from their platinum-based chemotherapy. And I think the two things probably interacted. I think, therefore, if we're going to take this forward, it may be partly that we have to apply a biomarker, but we may also have to think about how it relates to the chemotherapy. and your study ATLAS, which as you say was a negative study, but it was second or third line. So maybe the lack of platinum benefit as a clinical selection biomarker might have been relevant to actually how these trials fit together and how we make sense of them overall.
I totally agree. I think it's probably a combination of both. And the platinum refractoriness, the big question is what are the mechanisms of resistance and how much they overlap with PARP inhibitor resistance? That's an open question, as you said. And going back to the patient selection, we saw another trial in the so-called platinum-ineligible population. Dr. Rosenberg saw data from the BAYOU trial with durvalumab olaparib, randomized trial actually. And the first question to me was how you define platinum-ineligible patients, cis and carb fit. That was a big question, and we tried to answer that with Dr. Gupta and others. And the second question is, we saw a signal there with durvalumab having benefit compared to durva in patients who have some DDR alteration, similar signal to what you saw in your study. Again, very early, not practice changing, but a hypothesis generating. Any thoughts?
Yeah, so your first point I think is really interesting. This was another trial in platinum-ineligible urothelial carcinoma. And of course, we've all got used to the idea of how we define cisplatin-ineligible urothelial carcinoma. There are criteria, the Gaussky criteria. It should be said, those are largely down to kind of expert consensus rather than, you know, a sort of particular reason why you go for exactly those criteria. But they're established and we're used to using them. I think, and Jonathan Rosenberg, who presented the BAYOU trial, was very kind of open and honest about this. It is a difficult thing to write down a set of eligibility criteria for what platinum-ineligible urothelial carcinoma really means. They did include a requirement to have at least one of a list of criteria, so performance status 2, GFR below 60, and hearing loss and so on. But of course, those are the criteria for cisplatin ineligibility. So in addition, the investigators essentially were, as I understand it, were defining these patients as being platinum ineligible. Now, I believe this group of patients exists. I think it's a real phenomenon. I think these are patients we see in our clinic, and I think you know them when you see them. But it's quite hard to define it in objective ways. And as I say, Dr. Rosenberg was very open about that, and I think it's an interesting discussion that we're going to have more of in terms of thinking about this group of patients. In terms of the trial, as you say, it was a negative study for its primary endpoint in all comers, based on progression-free survival. But again, as in our study, they had a subgroup analysis. It was a planned secondary endpoint, and they did see a difference in progression-free survival in people that had a homologous recombination repair biomarker. It was a slightly different gene list to the one we used, inevitably. And so, again, consistent with the idea that we can possibly come up with a biomarker who might benefit from PARP inhibition, but there's going to need to be a lot of work to work out exactly how you refine that. What's the optimal way of selecting patients?
Totally agree. I think it's definitely encouraging to think about the right biomarker with PARP inhibition. Again, maybe germline mutations, maybe somatic with loss of heterozygosity in the other allele. I think definitely merits more investigation. Very quickly, Simon, before we conclude, we saw a negative trial, pembro-lenvatinib versus pembro placebo by Dr. Loriot and colleagues in this same population of platinum ineligible patients. Those were 80% were platinum ineligible and 20% cisplatin ineligible. Are you surprised that this was a negative trial with pembro-len, considering what we have seen in endometrial or kidney cancer?
I think it's a different disease, obviously. So I think you have to take it on its merits. I think this is, and perhaps both of these studies indicate that this is going to be a challenging clinical setting to operate in. Platinum ineligible patients are going to have short survival outcomes. Inevitably, they're going to be potentially more at risk of toxicities. Maybe that's one of the things to consider from this, that actually one of the primary questions when you think about how you develop a therapeutic option for this group of patients, is actually the toxicity profile may be one of the key things. Can you actually deliver the treatment in a sustained fashion? So I think it's a shame it was a negative trial, obviously, and probably not the way forward for this group of patients. But I think those are the sort of considerations we'll need to think about.
Very, very interesting to see at least data with IO plus angiogenesis inhibition. And, we're working on the manuscript now, so more to come. And before we conclude, I know we're running out of time here, but very quickly, Trophy U01 cohort 3, Pembro plus sacituzumab govitecan, antibody drug conjugate against TROP2. I had the chance to present the data in this platinum refractory second-line setting. Difficult population, response rate to prior platinum was only 15.15%. Median time between end of chemo and trial scanning was 1.6 months. Very difficult population. The response rate 34%. Of course, again, this is not practice changing, but do you think it supports further investigation of Pembro plus or any immunocheckpoint inhibitor plus sacituzumab govitecan?
Well, certainly. I mean, so I thought it was really interesting data. I think it's a provocative level of clinical efficacy. So certainly we want to see randomized data, and obviously there is phase 3 work ongoing at the moment. So I think it's clear, I think, that there is enough activity that hopefully that this is an agent that can find a position. So I was going to ask you, we saw data on this agent targeting TROP2. We saw data on enfortumab targeting Nectin-4. There was also data from Matt Gowski with a HER2-directed antibody drug conjugate. So all of these clearly have activity. For all three of them now, we have some evidence that combining with immunotherapy might be a sensible thing to do. How do we move forward with all of these agents? Do you think we're running into a problem just of a kind of traffic jam of how you fit all these into the pathway?
Someone, you asked a great question. And, about 5 or 6 years ago, you and me would probably not have this conversation because 6 years ago, we had no much data, right? Immunotherapy was coming up at the time. So I think it's a great conversation to have. It's a great quote unquote problem to have, how we sequence those agents, how you use them, because we have seen this significant improvement, progress in the field. And we have immune checkpoint inhibitors, antibody drug conjugates, like you mentioned, enfortumab vedotin, sacituzumab govitecan, the anti-HER2 antibody drug conjugates, and we have erdafitinib, FGFR inhibitor in selected patients. So I'm very pleased, to be able to have this conversation with you to begin with. I think the future, in my humble opinion, is probably about combinations. And I agree with you. I think antibody drug conjugate plus checkpoint inhibition looks a promising approach across the board. We have data with Pembro EV, Sachi Pembro, and Nivo plus the DS8201A from Dr. Galsky at ASCO GU. And I think the combinations are going to be tested in early disease settings. We have now 2 neoadjuvant trial data with Pembro EV. We're going to have more data with sacituzumab govitecan plus checkpoint inhibition from cohort 4 in the frontline setting in advanced urothelial cancer, cisplatin plus Sachi, followed by avelumab plus Sachi. And of course, the HER2 antibody drug conjugates that require some patient selection there. And the interesting thing is enfortumab and sacituzumab do not require testing for the biomarker, but the HER2 maybe. So I think we need more data in the future about combinations and the optimal sequence of those agents.
And can I ask you just about sort of more the practical implementation of these agents? Obviously been a lot of data from phase 2 studies that will have been done in centers that have a lot of experience with these novel agents and how to do that. As we go into phase 3 and then potentially at some stage into routine practice, how do you think this will, do you think this is something that practicing oncologists are going to find easy to bring into their treatment paradigms? Is this just fancy chemotherapy and we just need to kind of think about it in the way that we've always given drugs of that sort? Or do you think we're going to have to learn about new toxicities, training of our teams to actually deliver these agents safely?
I think it's important, critical, I would say, to make sure we have a good understanding of the mechanism of action and toxicity profiles. You raise a great point, Simon, because if you think about it, these combinations may have probably additive toxicity, and they seem feasible, they seem manageable, which is good, but you have practical questions, right? If you have diarrhea, right? Is that because of the ADC or checkpoint inhibition, right? How do you manage that? We have similar questions in first-line kidney cancer, right, with TKIs and IO. And I think the future, I think, probably requires randomized clinical trials with, I would say, classical endpoints of probably overall survival, if we talk about first line or second line urothelial advanced urothelial cancer. And if we go to the earlier setting, like neoadjuvant, adjuvant, I think a combination of pathological complete response and event-free survival, with event-free survival having the highest weight, would be the right endpoints. But I think thinking about toxicity and managing toxicity early and properly will be key to make sure patients are taken care of and that we can treat them, right? We maintain some degree of dose intensity as we can in order to use the combination safely. But I think it's we need these randomized trials to collect more data on both efficacy and safety endpoints. Would you agree with that?
I think so. Yeah, and it's interesting you talk about, moving into the neoadjuvant and adjuvant space. Of course, inevitably people will start to think about non-muscle invasive disease as just bring ourselves full circle. The toxicity profiles then become increasingly important, and also thinking about actually how do you deliver that within a routine clinical practice for this disease.
Absolutely, I agree with you, and I think the beauty, of the state now is that we have more options than before, as you and me talked about, and I think it comes down to right clinical trial design and collaborations, right? How can we work together to accrue in those properly designed trials, evaluate and validate biomarkers, and hopefully in the future, move more to a more personalized approach. That's my vision for the future, Simon. It's a high bar. It's hard because of the biomarker validation high bar situation, but hopefully we can get more individualized in the future, right?
I think so. I think that's the way forward.
Excellent. Thank you so much, Simon. Great to discuss with you. I enjoyed this, and thanks to the audience for hearing our conversation.
Thank you.